Why are doctors not compassionate? And can we train them to be? I know there are compassionate doctors everywhere. And if you are one of them, you're a gem. This talk is not about you. The reality is, too many physicians are indifferent in a profession where we cannot afford to be. This talk will explore this fundamental problem that is as complex as human nature. In it, I will argue why I believe so many physicians lack compassion and how we can change. The question is, would you? Would you change? Or would you choose the only possible other alternative, which is to become obsolete? What is compassion? The word comes from the Latin compassio, meaning with passion, a feeling of deep sympathy and sorrow for another stricken by a misfortune, accompanied by a strong desire to alleviate the suffering. I mean, it is intuitive to think that doctors and compassion go hand in hand. I mean, just as it's intuitive to think that all judges are fair, or that all airline pilots are disciplined, or better yet, that all bull riders are heterosexual. Are they? I am an emergency physician, and for the past 5 years, as the director of patient experience in my emergency department, I've been trying to make doctors more compassionate. I've got good news and bad news. Good news, it's a beautiful day today. Bad news is you cannot teach compassion. A person is either compassionate or not. If they are, and they're a good physician, they're blessed. You're blessed. If they're not, it can't be taught. You just can't instruct and expect someone to acquire a virtue. You know, in real practice, physicians' time is costly. The schedules are hectic. The turnaround is huge. I mean, teaching compassion, say, in the emergency room, is like teaching compassion in hell. It's a bit late and hot, if you ask me. When it is learned, it is over time, a long time, after a life of experience, after softening the heart, breaking the spirit, taming the pride. Try to teach that. It's like teaching you how to love. And when you try to teach it, it's almost insulting. Telling someone to put themselves in someone else's shoes is demeaning. It's tiring. To be compassionate, you need to be quite a character, not a softie like many people think. To be compassionate, you need to be hard, solid, hard on the inside. On the outside, you need to be soft and sweet. You need to be like chocolate-covered diamond or something. You know what? I think that's the scientific reason why women like compassionate men. Chocolate and diamonds. Don't teach compassion. If you are compassionate, be it. Let other people see it, hear it, feel it. Because love, compassion, sacrifice, forgiveness, goodness, charity, all these things are virtues. You can't teach them, but they are contagious, and you can infect others with your own. So what do? We go around infecting others with our own compassion. That sounds very nice, but not a very good plan. My experience has taught me that in order to change an outcome, you must dissect the problem. Why are so many doctors not compassionate? Two main reasons. Number one, circumstances. Number two, survival. Doctors are human, just like any other human. There are compassionate doctors and not compassionate doctors, just like there are compassionate priests, imams, rabbis, preachers, and not compassionate ones, or compassionate lawyers and not compassionate lawyers. Did I just say compassionate lawyers? No, seriously. Thank you to all attorneys for forcing us to abide to a standard of care. Without you, we would be poor or richer. No. Poor. Should a doctor be compassionate in order to practice medicine? Is it a prerequisite? I will assume that when a patient comes to a physician asking for help in the vulnerable state that illness creates, it is the physician's responsibility to be competent, but also not to antagonize the patient, not to belittle the patient, not to irritate them or talk down to them, not to use a body language or a tone of voice that communicates indifference, disinterest, superiority. And I'm not even talking about the fact that they're paying. They're paying to be treated like this. I mean, in which industry is this acceptable? You would think that if you sat with a rude physician and you just showed them, if you could just only show them the number, how their actions are hurting the patients, the families, themselves, the hospitals, the likelihood of increasing lawsuits, the decreased likelihood of getting reimbursement, you would think they would change? Nah. Been there, done that. Words and guilt only make them feel more indifferent, makes them passive aggressive, and it makes them hold a grudge against you. Why? Why does it matter anyway? Lately, this issue and compassion and physicians has become, let's just say, important. I mean, for years, it did not matter. For years, physicians were rude, blunt. In many countries, they continue to be with no plans to change. That is the norm. That's what's expected. Never has there been a time where we've been so united to want change. It's no secret why. In 2013, the Center for Medicare and Medicaid Services created an inpatient hospital-based value purchasing program where patient satisfaction became directly related to reimbursement. They did this using the Hospital Consumer Assessments for Healthcare Providers and Systems Survey, also known as HCAHPS. And guess what? In early 2016, ER caps are coming. This means that patient satisfaction and reimbursement will be directly related in the emergency room as well. All of a sudden, it matters. It matters a lot. But if it's so important to all of us, why is it so hard to implement? Reason number one why so many physicians lack compassion: circumstances. You know, the specialties physicians choose depend on personalities, circumstances. What makes a doctor want to be a pediatric oncologist versus a radiologist, versus a urologist, nephrologist, family practitioner, surgeon, cardiologist, emergency physician? Let's take emergency physicians, for example. They're a group of younger practitioners who usually tolerate chronostress, who are more likely to want risk, uncertainty, who want a challenge, change, who are more likely to be impatient and more likely to seek rapid gratification. I'm not saying that. There are studies confirming this, just as there are studies that characterize the type of person that will fall into another specialty. Not only circumstances of this kind. How about other circumstances, such as upbringing, genetics, life experience, psychological profile? You are telling me that these characteristics don't have anything to do on how a physician handles a patient? Take, for example, a physician from a different culture who is bright, brilliant, has been raised by his father, no mother, no sisters, only brothers, who was raised under political oppression, poverty, and came in this country and fought tooth and nail to be board certified and has the character to do it. Recently divorced. All of a sudden, lost his only beloved daughter to a son-in-law he hates. This guy comes with a whole bunch of luggage. You're going to tell me he's unique? No. No, we all carry a whole bunch of luggage. This guy is a problem solver. He comes in looking for the patient. Who are you? The wife? I'm the doctor. You're the patient? I'll tell you what to do. Don't tell me what to do. This is what you've got. You got a urinary tract infection. Here's your prescription. Goodbye. You tell me that you want to teach this guy compassion? Good luck. Now, I just gave you the physician perspective. How about the patient perspective? Say a 78-year-old female. Her husband is 85. He's been ill for 5 days. She calls her daughter, says, "Sonny, your father's not feeling well. Mom, take him to the doctor." "Well, I'll do that, but the doctor's schedule is busy for 2 weeks. In a day or two, if he's not better, I'll take him to the emergency room." But that night, he deteriorates. She calls 911, and what a turmoil it is to have paramedics in your home. They want to give her a ride, but she says, "I'm going to stay behind because I want to gather his things. I want to look for his medications." So she's stuck. In the middle of the night, she knocks at the neighbor's door, and he gives her a ride to the hospital. She gets there. She looks for her husband, can't find him. "No, ma'am, he's not here. He happens to be in the hallway because there are no beds. Wait here 15 minutes and we'll bring you in." An hour and a half later, she's still waiting. They forgot about her. Finally, she goes into the room, gets lost on the way there, and she arrives in the room, and the nurse, "Hi, are you his wife?" "Yes, I am." "Did you bring his medications?" "Oh, I forgot him in the car." "Ma'am, we need his medications." Has my husband seen the doctor yet?" "Well, the doctor's very busy. It's very busy tonight." She speaks to her daughter. "Mom, my flight is leaving in 2 hours. I'll be there tonight." She's waiting. Should I go to the bathroom? Should I go downstairs to the cafeteria? I'm thirsty. I don't want to miss the doctor. She's standing at the door watching everybody go by. I wonder if that's going to be my doctor. I wonder if that's going to be my doctor. Finally, 3 hours later, the king walks in. "Hi, are you the wife? I'm the doctor. You're the patient. You've got a UTI. Here's a prescription. Goodbye." Houston, we've got a problem. We are speaking different languages. Reason number 2, so many doctors are not compassionate. Survival. No one knows how to survive better than animals. Watch this video. Here, you see a leopard being chased by a mother wildebeest. The mother wildebeest wins. She acts in a manner that is consistent with her biological state of mind to protect her offspring, just like we do. Here, the mother wildebeest wins, but most of the time, the mother wildebeest loses to the leopard. And what does the mother wildebeest do when she loses her offspring to the leopard? She turns around and walks away. She walks away because failure to do so will guarantee her extinction. Everything she does is to increase her likelihood of survival. I remember running a pediatric code in a 4-year-old boy. He was playing in his driveway when a family car came and hit him. Paramedics brought him in full cardiac arrest. And I remember we did everything for this little boy, like we would do for every code. But after a while, I could see Mom and Dad from the corner of my eyes standing at the trauma doors. And I said to myself, it's time. It's time I take a step back and tell them that the likelihood of bringing their little boys back is not good. And so as I stepped back and faced them while the code was still running, they asked me if they could approach. And I did not have the gut to say no. And before I know it, Mom's at the foot of the bed, holding her little boy's foot. And now she's kneeling down, trying to stay away from us. And as we continue to run this code, she's looking up at me and she's going, please don't stop. Please don't stop. That day, the leopard got that little boy. And I had to turn around and walk away for my own survival. Now you tell me something. When you ask me to be compassionate in a case like this, what do you mean? When you ask me to put myself in other people's shoes, what do you mean? This woman will go on to mourn forever. I have to see the next patient in an emergency room that is packed. Now, who are we to say what the level of compassion should be for each and every one of us facing a similar scenario? Every person has their own internal defense mechanism for facing a similar scenario. I mean, it is a dangerous thing to start playing with other people's pain in your own mind. It might break you. It will break you. You know, those who are compassionate, case after case after case after case, those who really have it in them, they have a way of seeing life, a way of being that is special. Let's just say they can handle it, or they have the ability to endure the pain that comes with feeling. In reality, their true skill is this ability to detach. They get in, they feel, they get out. They're crying with one patient and they're smiling with the next one. You would almost think that they're faking, but they're not. They're not. They're just being who they are. How else could they be? You know, for every patient, their illness is a disaster. You're going to say the case that I just gave you is unique. Yes, it is. It is intense. But for every ill patient in a hospital, in the emergency room, their illness is a disaster. Do you know what the definition of a disaster is? The definition of a disaster is when bad things happen to you, or to you. Because when they happen to someone else, it's just a bummer. I know. I've always had a hard time with this one. Should I laugh or should I cry? But it's so true. If every other person's disaster was your own, we could not survive. We couldn't subsist. You know, the insult to the person living this pain is not your inability to live their pain, but your indifference. Your indifference. A tornado has just ravaged their homes, and you're just walking through the rubble, kicking the family picture. I mean, it's powerful enough to have a sick person sit up and look at you up and down, and you go, whew, are you? Who are you treating me like this? They don't want your tears. They don't want your pity. All they want for you is to tiptoe through their rubbles. To tiptoe through their rubbles. They're not asking for you to live their disaster. Tiptoe. You could even step on one of their most prized possessions, and if you said, I'm so sorry, they would go, that's okay. That's all right. But indifferent people just do this. They're just walking through people's rubbles, completely disregarding their feelings. So, we still have a problem. How do we solve it? There is another word. There is another word. And that word is sensitivity. You're going to say it's semantics. It is not. It's a complete different set of expectations. All you have to do is learn how to tiptoe through people's rubbles. The title of this presentation in reality should be How to Walk Through Sacred Grounds. Now, the reason I've said all of this, the reason for this whole presentation up to this point, is for you to understand that in order to solve this problem, you will not be successful if you attempt to change a physician's personality trait. That will not work. Do you know who you're talking to? These are highly motivated people. It took 20 years to get there. They're extremely driven, well-shaped and formed. They speak one language only, one language, and that is the language of methods. You need to speak through their language, methods. There are scenarios, and these scenarios should trigger a set of responses. It requires the ability to recognize and respond. That's what sensitivity is. Learned through conditioning. Forget all the love and dedication, compassion. That is good. That is the ultimate. And I'm going to go as far as saying as that is the purpose of life. But that is a choice, whereas sensitivity is a duty. Let me repeat this. Compassion is the ultimate. It is a walk through life, but it's a choice. Whereas sensitivity is our jobs. That is what we're paid for. Does it matter? Does it matter that it's not a natural outpouring of love, but rather a learned behavior? No. What matters is how patients feel. We do this all the time with our children. They fall, we pick them up. Oh, poor baby, bad floor, bad floor. Here's a kiss. Are we faking? You tell me. Remember the actor, comedian George Burns? He said it so well. He said, sincerity is everything. If you can fake that, you've got it made. Are we being hypocrites? We are not being hypocrites. We're being asked to be compassionate, to be loving, case after case after case after case, where every single patient is living a disaster. So, how do we do this? It's very simple. It sounds complex because we've never enforced it, but once we do and it becomes the norm, it's as if there was never any other way. You're going to meet resistance. Do you know why? Circumstances, survival. But unless your leadership, understands that there is a problem and acknowledges it, you will never solve this problem. There are new standards, but these standards have been established long time ago. There are many books on this topic. What has been deemed appropriate to render a patient satisfied has been established long time ago. I have summarized several books and I've come up with 12 rules.
Patient Satisfaction Checklist. 12 steps to take with every patient. Number 1, smile, knock, shake hands, give your business card, introduce yourself, and acknowledge everyone in the room. Number 2, sit, sustain eye contact, use a positive tone of voice and body language, and look as though you enjoy what you do. Number 3, communicate what you know already and allow the patient to speak without interruption for 2 minutes. Number 4, use continuers, paraphrase, empathize. Do not argue and redirect by asking, what is it that worries you the most? Number 5, excuse yourselves when you answer the phone. Get interrupted. Turn your back to the patient, or you must leave the room. Number 6, tell the patient simple exam findings, their vital signs, general observations. Communicate. Number 7, attend to simple requests right away, such as raising the bed, food, water, blankets, and bathroom needs. Number 8, tell them what you're going to do, what tests you will order, medications you will give, when it will start, and how long it will take. Number 9, give regular updates. Number 10, explain pathology, findings, diagnosis, plan and consultations. Ask if they understand and if they agree with the plan. Number 11, if there's a shortfall, apologize. Validate the patient, fix the problem, and take action to prevent it from recurring. Number 12, ask, is there anything else I can do? Touch the patient, thank everyone, explain what could have happened had they not come in. Do all of this, and we promise you, you will be more fulfilled, happier, and more importantly, so will your patients.
These are my rules, but you could develop your own. You could develop your own strategy for solving this problem. The goal is to instill a method where every single physician uses this method, a little bit like many corporations do in order to keep their clientele satisfied. You cannot leave it to individuals' compassion level. In my system, I have developed 3 phases. Phase number 1, physicians come in and they listen to these 12 rules. In my emergency department, I've created 2 areas. Each of these areas are in the physicians' cubicles, where physicians sit away from patients. Physicians come in for their shifts, they put their earphones on, and they listen to the iPod audio video that I've created, these 12 rules. It takes 1 minute. It's like a mantra, a prayer. They listen to it, and then they go on to work. It takes 1 minute. They do this for 1 month, and then after that, we go to phase 2. During phase 2, physicians are tested on these 12 rules. 1 rule a month. They come in during the shift that they're working and that I'm working, and I call them to a room where I've placed 3 nurses, 1 acting as a patient, 2 as family, And I call the doctor, are you free for a minute? Yeah, I am. Come on over here to room number 12. They come in, they go, what's up? I'd like you to do rule number 1. What? Rule number 1, do it now. Now? Now. I filmed them. It takes 30 seconds. Rule number 1 is knock, introduce yourself, acknowledge everyone in the room, smile, and give you a business card if you've got one. Do it. It's actually pretty funny. It's pretty funny to watch them do it. You film it, they got one chance. That's it. They miss it, doesn't matter. And then I do this with every physician. I collect it together, form a little 3-minute video, and upload it on my iPod. Now, they're not obliged to watch it, but they will. They really want to see themselves. They want to compare themselves and look at other people do it and laugh at them and laugh at themselves. Let it go viral. You do this 1 rule a month for 12 months. And during phase 3, which is the last phase after a year, every physician is scheduled to come in once, 3 hours before the beginning of their shift. They are paired to a physician who's already working that shift. And their duty is to supervise that physician with all the patient encounters during those 3 hours and rate them on the 12 rules. They do this once. They are paid for those 3 hours a base salary. And then, on another day, they switch roles. The goal is to create a standard. The goal is to make this standard a norm until everyone does it, until it becomes the way of being, until it becomes the way it is, as if there was never any other way. Thank you.